Welcome to this explainer. Today, we're unpacking the wild, behind-the-scenes world of healthcare delivery, specifically looking at it through the lens of sustainability accounting and operations. I was absolutely amazed to learn just how much massive external pressures dictate how these facilities actually operate, manage their money, and even measure their own success. It's a hugely complex system, but by using the SASB standards as our guide, we're going to see exactly how it ticks. All right, let's just dive right into this.
To kick things off, let's anchor our entire analysis on a direct quote from the SASB industry standards. Demand for healthcare delivery services is driven largely by insurance coverage rates, demographics, illness, and injury rates. So this is our core thesis today. Healthcare doesn't just operate in a vacuum, right? A hospital's patient volume, its revenue, and its day-to-day operational stress are entirely at the mercy of these macro-level demand drivers. If we really want to understand the business of healthcare, we absolutely have to start right here.
Here's our roadmap for today. We'll be looking at the drivers of healthcare, the insurance coverage factor, shifting illness and injury rates, quality and patient satisfaction, and finally, the cost of compliance.
Starting off with Section 1, the drivers of healthcare and the macro view of the industry.
Okay, so there is this fascinating foundational tension that every single hospital, clinic, and rehab center faces. The healthcare delivery industry is just incredibly resource-intensive. You have these staggeringly high fixed costs. I mean, think about the highly specialized facilities, the ultra-expensive medical equipment, and the highly skilled labor force of doctors, nurses, and technicians. But here's the catch. Those massive fixed costs are actively competing against an intense and ever-increasing regulatory focus to actually reduce the cost of care while simultaneously improving patient outcomes. It's a constant, incredibly high-stakes balancing act between surviving your own overhead and delivering better, cheaper care to patients.
Let's move right along to Section 2, the insurance coverage factor, and how facilities manage their mix of patients.
So healthcare providers serve populations with a really diverse mix of insurance statuses, and managing this mix is absolutely critical to their survival. On one hand, you have patients with private insurance or government-sponsored insurance. But on the other hand, care delivery entities will always face the very real challenges associated with serving uninsured and low-income patients. To manage this, hospitals have to develop strategies like financial assistance programs, which provide no-cost or discounted care, and they also participate in state or local indigent care programs. An entity's ability to develop innovative pricing structures that balance uninsured populations while expanding their privately insured patient base, well, that's a massive driver of their revenue and overall stability.
Now, because of this incredibly complex insurance web, there's immense regulatory scrutiny on pricing transparency. To measure how well entities are responding to this, the standard specifically tracks the 25 most common inpatient and outpatient services for which a provider makes pricing information publicly available. That's right, 25. Healthcare providers have to disclose this exact metric, along with what percentage of their total procedural volume these 25 services actually represent. So whether they're posting a precise price or just a range on a public website, transparency is rapidly becoming a non-negotiable metric for both patient trust and regulatory compliance.
Moving along to Section 3, shifting illness and injury, or what we might call the climate domino.
We established earlier that illness and injury rates are a primary driver of healthcare demand, right? But what happens when those rates fundamentally change? The SASB standards highlight the physical risks and major shifts in disease profiles associated with climate change. Extreme weather events don't just threaten the hospital's physical infrastructure, they literally change who walks through the emergency room doors. Providers have to plan for an influx of patients suffering from heat-related illnesses, like asthma caused by ground-level ozone. They have to prepare for waterborne diseases like cholera following increased flooding. We're even seeing the potential for vector-borne diseases, like malaria and dengue fever, to shift into previously non-tropical regions, alongside human developmental disorders stemming from food scarcity. Hospitals literally have to build flexible capacity today just to treat the evolving diseases of tomorrow. It's pretty wild.
This brings us to Section 4, quality and patient satisfaction, and how we track the fallout when these macro demand drivers stress the system. When you combine high patient volume and complex illness rates, you put immense strain on operations. And how do we measure the failure of those operations? Through what are called serious reportable events. These are serious, largely preventable incidents that are of massive concern to both the public and regulators. We're talking about major things like surgical events involving the wrong site or the wrong patient, severe medication errors, in-hospital patient falls, or even releasing a patient with impaired faculties without an authorized person. Entities are required to aggregate and disclose the total number of these events across all their facilities, from the big hospitals all the way down to the outpatient centers. It's a stark, undeniable metric of the quality of care.
And the tracking gets even more granular from there. Healthcare systems don't just track single catastrophic events, they must diligently track hospital-acquired conditions as visual proof of their operational stability. So providers are tracking the incidence rate of conditions that patients acquire while actually inside the hospital. This includes things like healthcare-associated infections, pressure ulcers, postoperative sepsis, and deep vein thrombosis. And the incidence rate is calculated pretty simply. You take the number of patients diagnosed with the condition, divide it by total hospital admissions, and multiply by 100. Improving these specific metrics preserves the hospital's brand value and drastically reduces the excessive costs associated with prolonged patient stays.
The final piece of this quality puzzle is the unplanned readmission. This is defined as a previously unscheduled patient admission to a hospital within 30 days of their prior discharge. Now, you might be wondering why track this so closely? Well, because an unplanned readmission is the ultimate red flag. It indicates an unresolved acute illness, or maybe the development of new medical complications from that first stay, or even severe gaps in outpatient care. High readmission rates basically mean the care delivery was ultimately inefficient, forcing the system to expend double the resources on a single patient episode. Nobody wants that.
Let's move into our fifth and final section, the cost of compliance and how entities actually protect the internal system. Remember that tension we talked about earlier with those high fixed labor costs? Well, the healthcare delivery industry is incredibly dependent on a skilled workforce, and, relative to other industries, it actually has one of the highest rates of employee injury and illness. To track this, entities use the Total Recordable Incident Rate, or TIIR. The math they use to track this is actually super fascinating because it standardizes the risk across any facility, regardless of its size. Here's how they do it. You take the count of recordable work-related injuries, multiply by 20,000, which represents the total hours 100 full-time employees would work in a year, and then you divide that by the total hours actually worked by all employees. Boom! Managing this TIIR metric effectively reduces workers' comp costs, boosts morale, and really aids in retaining those highly coveted physicians and nurses.
Beyond just labor safety, to round out this whole domino effect, facilities constantly have to juggle other massive fixed compliance costs that dictate their financial sustainability. For instance, they generate significant medical and pharmaceutical waste, which has to be rigorously tracked by metric tons and categorized by its disposition, like was it incinerated, recycled, or sent to a landfill. They also face immense pressure to implement administrative, physical, and technical safeguards just to protect personal health data. A single data breach can result in massive legal proceedings and huge monetary losses. And finally, hospitals are incredibly energy-intensive. This means they must carefully track their total energy consumed in gigajoules, trying to optimize the balance between purchased grid electricity and renewable energy to limit their exposure to fossil fuel price volatility. It is a lot to manage.
So, we've seen how macro drivers like insurance demographics and climate-driven illness shifts cascade all the way down into granular operational metrics like readmission rates, pricing transparency, and waste management. It's a highly interconnected web where external pressures are constantly challenging internal fixed costs. Which leads us with this final thought to ponder. As climate change continues to shift global illness rates and as patient demographics rapidly evolve, are our healthcare delivery systems tracking the right metrics to remain resilient, or will the storm ultimately outpace the accounting? Thank you so much for joining me for this explainer. Keep analyzing, keep learning, and I will see you next time.